Thank you for the opportunity of speaking with you here today. By way of disclosure, yes, I work for Johnson & Johnson Vision, and today I want to talk to you about the public health burden of myopia, particularly as it applies to the United States. So let's start off looking at prevalence, and we'll first of all start off with children. This extensive systematic review and meta-analysis looked at changes in prevalence of myopia with age across different countries and regions of the globe. The one interesting data point I want to draw your attention to is the data for the USA. There were no studies that met the inclusion criteria for children older than 5 years. And this is probably reflective of the attitude and approach we have had in the United States up until now. That is, myopia is no big deal. This graph plots the data from the previous table, and we've added here some numbers from Japan and South Korea, although I do want to point out that these are from non-cycloplegic refractions. There are a few pieces of data for the United States. The lower one here comes from a study in a small region in California in 1993. So that's coming up to 30 years old now, that data. And the curve for 2018 in the United States derives from a pediatric population enrolled in the Kaiser Permanente health plan, and this was published by our co-presenter Dr. Mojahedi. Now because of the population of that study, we would probably say it's not necessarily representative of the greater population and may overestimate the myopia prevalence. So we don't have much on children. What about on adults? Well, this very important study from the National Health and Nutrition Examination Survey, published in 2008, plots the myopia prevalence for different ages, for different races, different sex, and we also see some high myopia data shown as part of this graph. The key thing here is that when averaged across these different subpopulations, the myopia prevalence between the age of 20 and 59 is actually, surprisingly, above 50% in the United States population. And it drops off after 60, and this most likely represents an increased prevalence of myopia in the younger generations. Perhaps more important than the prevalence data itself, though, is the change in prevalence across time. This data comes from the same authors as the previous slide, and it compares the prevalence estimates for National Health and Nutrition Examination Survey data from the early 1970s with the more recent data. Now, there's certainly some methodological challenges in putting this together, but the authors did a careful and hopefully unbiased look at this information, and they estimate that the prevalence across the nationally representative population aged 12 to 54 years increased from 25% to 41.6% over this time period. And this is a very important set of data because it does feed into our projections as to what is going to happen in the future. This landmark publication by Holden and co-workers is our major source of global projection for myopia prevalence across time. This graph plots these projections, and I have adjusted and dovetailed the NHANES data from the previous slides into this. It shows a projected increase in the United States from 17% myopia prevalence in 1970 to 58% in 2050. Rather incredible. Perhaps even more worrying, though, are the projections for high myopia, where we see an increasing gradient in the curve continuing through to the year 2050. So just how good are these data? Well, we know with a high degree of certainty that myopia prevalence has increased in other parts of the world, and we suspect that the major contributing factor, a reduction in time spent outdoors, applies also in the United States. Our own independent analyses are consistent with the trend seen here. Maybe the most sobering statistic from the Holden publication is this, however. We know East Asia has a major problem with myopia right now. Well, the Holden projections suggest that the prevalence of myopia and high myopia will be greater in 2050 than that currently observed in East Asia. And already, pathologic myopia is the leading cause of irreversible blindness in Taiwan, China, and Japan. And this is just a wow statistic to look at. I don't need to explain to this audience the implications of high myopia with respect to pathology, and of course, preventing these complications is the main reason we want to target myopia progression. But what is the likely public health impact in terms of vision impairment? My colleague Dr. Bullimore and I presented this poster at ARVO this year. We took data from Tiedemann et al., who had published on vision impairment from a large Dutch population versus age and refractive error. One of the key things about this is that it is agnostic with regard to the actual disease or complication that causes the vision impairment. We combined this information with a published population pyramid projection, our own models of refractive distribution for a given myopia prevalence, and actually used a more conservative estimate than the Holden data of only 50% myopia prevalence. The outcome is a numerical projection of vision impairment for the year 2050 across age. We can estimate the effect that myopia has on the distribution, and it tells us that some 30% of vision impairment is actually solely attributable to myopia. Contributing to this effect, we see from our previous review of prevalence of myopic maculopathy that there is truly no safe level of myopia, and that each increase by 1 diopter of myopia increases the risk of myopic maculopathy by about 67%. While low myopia carries modest risk for the individual, the population burden becomes substantial through the sheer number of low myopes. In one study in Singapore, less than half of study subjects with myopic macular degeneration were classified as high myopes, even with the more liberal definition of -5 diopters. And indeed, over 40% of subjects with myopic maculopathy were low myopes. So to achieve an overall population reduction in morbidity from myopia, it is important that we slow progression in all myopes. We certainly recommend treating all myopic children under 12 years of age and all moderate myopes up to 16 years of age. Finally, these numbers will of course have economic impact. Chua and Foster, in the book Updates in Myopia, just published last year, estimate the cost of vision correction in Asian adults to be $328 billion per annum, and specialist care for high myopes will be about $250 billion per annum. Our own research for the United States suggests an annual burden of around $90 billion, which will rise to over $200 billion by the year 2050. Amazingly, this puts the cost of myopia above that for congestive heart failure, lung cancer, breast cancer, and colorectal cancer using data from the Milken Institute. I just wish to finish off by taking some quotes from the American Academy of Ophthalmology's task force on myopia. This is a paper that was just published last year, and again, co-presented Dr. Mochahedi is first author on this. And you'll see in this paper it says the growth in myopia prevalence, especially in East Asia, paired with the projected international growth in myopia prevalence and its secondary complications, are a cause for alarm. In addition, it says, although higher degrees of myopia carry a greater risk of visual impairment to the individual, the population-based burden of lower degrees of myopia remains considerable. I hope you'll agree with me from the evidence that you've seen today, plus the opinions of experts from around the world, that the time to act is now. We need to slow down the progression of myopia. I look forward to the opportunity to answer any questions you might have after the other speakers. Thank you very much.
Thank you, Dr. Galvin and Dr. Lee, for the opportunity to participate in this webinar, and good evening, everybody. My disclosure, I'm on the Scientific Advisory Board as an unpaid member and have no financial or IP conflicts of interest. The objective of my session is to review the correlation between near activities and myopia and discuss current recommendations and research directions. Now, for all of us, myopia has certain associations that's embedded in our culture. For many of us, the myope is the individual who's the reporter of the world, and the introvert who's passive, as opposed to the emmetrope who's the man or woman of steel. For me personally, myopia meant peril growing up on the schoolyard, being the person who's not quite as confident as my non-myopic peers, but with a feeling of intellectual superiority, which didn't always work out well. But too much about me. We're going to talk about the association between reading and myopia and the effect that reading has, or near activities have, on the development and progression of myopia. Now, the idea that how we use our eyes affects their growth has been around for a long time. It was in the 16th century that Bartish was the first to observe that those who spent their time reading fine scripts in poor lighting were much more likely to be myopic than those who did not. It was in the 1800s that Professor Ware was really the first to demonstrate that military conscripts, individuals who were drafted into the army, had a much lower prevalence of myopia than those Oxford students who had a higher degree of myopia. He also acknowledged that it's highly unlikely that army individuals had the means to afford glasses, let alone get an eye examination. The idea of how we use our eyes and how it affects our ocular growth compared to our genetics in the determination of ocular growth has been long-lived. One of the first investigators was Francis Young, an optometrist from the Pacific Northwest, who looked at the prevalence of myopia in indigenous populations. He found in those individuals who grew up not in a Western culture and environment, who did not have formal educational curriculum, the rate and prevalence of myopia was very low. But within 2 generations, the prevalence of myopia had reached that of Western curriculum, Western societies that spent much of their time in near work environments. We also know that the prevalence of myopia is higher in occupations that require individuals to spend time looking at spreadsheets, graphs, ledgers, as opposed to individuals who spend their time laboring outdoors, looking at the horizon, and not doing near work. We know that the rate of myopia progression is greater in the school year compared to the summertime. We also know that this seasonal variation is constant and consistent in different populations of different ethnic backgrounds. We also know that individuals who grow up in the city, children who spend time in the city versus those who spend time in the country have a much higher prevalence of myopia. The confines of the city environment, the more time spent indoors as opposed to outdoors, perhaps contributing to the progression of myopia. What about the issue of myopia in education myopia and intelligence? Is education and intelligence simply a proxy for amount of time spent reading? That study has been done and has shown again that there's a strong correlation between level of education attained and the prevalence of myopia. And we all know that in most of our Asian countries, 90% of college students and graduate students will be myopic. What about the issue about intelligence per se? Well, again, for those insecure myopes in the schoolyard when I was growing up, we justified our social awkwardness and infirmity with the belief that we were smarter than those who tormented us. And indeed, studies bore us out. So vindication at last that those who are myope more likely to have higher intelligence. How we use our eyes in the educational environment has also been studied. In an interesting study performed in Israel, investigators looked at the prevalence of myopia in boys and girls who attended Orthodox schools versus general schools. What they found is that the highest rates of myopia were seen in those boys who attended Orthodox schools compared to girls who attended the same schools from the same genetic stock. Well, there was a difference in how they used their eyes, and that the boys would read the Torah for longer periods of time, often while shuckling or doing what you can imagine would be an extremely difficult accommodative demand, focusing on the small print as you're constantly moving the working distance between your eyes and the printed material. We also know that not only is how much we read and what we read important, but where we do the reading. It was in the early 2000s that investigators saw that there was a strong correlation between time spent indoors or outdoors and the progression of myopia. And again, whether you're looking at populations in Asia or populations in Scandinavia, this near work to outdoors ratio has been a consistent predictor of those who will experience a higher degrees of myopia occurring at a faster rate. So we can see it's not easy and simply possible to look at reading in isolation. You have to look at the environment which what reading is taken care of, both physically as well as educational environment. Not only is the research question clouded by these variables, it's also clouded by how the research was done in the past. Historically, studies were prevalent studies, not longitudinal incidence studies. Not all parameters were measured. There's been a lack of compliance, lack of randomization, a lack of control group on intervention studies. It's important to acknowledge the first investigator, Carla Zadnik, an optometrist from UC Berkeley, who really was the first to show that in a longitudinal fashion, the risk factors that would lead to myopia. Similar investigators have tried to apply the same rigor, trying to quantitate the amount of near work, the actual amount of screen time, the amount of outdoor time, and the parental risk factors in the determination of myopia. And what have we found and what can we say? Well, we can say clearly that reading, writing, and less outdoor times are risk factors for progression of higher degrees of myopia. Interestingly, we can't say that screen time and TV per se are a risk factor. What's the best study to date? And that was one that was just published in PLOS, where investigators in Taiwan and Wilmer looked at over 14,000 publications using careful evidence-based medicine criteria in order to come up with validated conclusions. And they found only 14 publications that would allow recommendations. And what was the recommendation? Yes, the recommendation is that reading is an important variable in the determination and progression of myopia. And what are the recommendations? Well, the recommendation could be to decrease the amount of time spent reading to reduce the risk of children developing myopia. Now, I don't think any of us in this audience will say read less, but many of us will say perhaps we should be reading differently. It's important to talk about a naturally occurring experiment that occurred in the last 18 months, courtesy of the sponsor COVID-19, not approved by the IRB in any country. Researchers in China had been studying over 120,000 Chinese school children, checking cycloplegic refractions every year for a period of 6 years. When COVID enforced a lockdown and a shift to home learning, you can see that during that 6-month time period, there was a marked increase in the prevalence of myopia. Whether this will be sustained, whether there'll be any rebound, it will be determined by future study, but clearly being forced indoors and forced to do our learning online was not healthy for our eyes. In a similar study, researchers found that imposed lockdown made low-dose atropine much less likely to be effective in delaying the progression of myopia, as the rate of myopia progression increased by 50% during lockdown. Now, as Dr. Zadnik and colleagues have said, it's extremely difficult to prove causation and not just show correlation. And one of the biggest limitations of coming up with conclusions is that we have to rely on questionnaires in determining amount of time that our children spend reading, doing near activities. Well, for a long period of time, we've tried to modify the behavior of children. Back in 1921, this reading desk was sold to prevent children from getting too close to reading material. In the early internet days, the Myopter could be purchased to prevent your children from accommodating or converging as they read. Not necessarily a big seller, but all throughout the internet. But one thing we all should be aware of is a new device which will have import in those of us who conduct myopia research. The CloudClip is a device which is a built-in sensor. It records the amount of illumination, but it also records the distance between the child's spectacles and the reading material. This can be Bluetooth to the parent, and not only that, the instrument will buzz when the child gets too close to the reading material. So BF Skinner would be happy. Again, you can use this from a research or an individual basis. And what's been interesting is that in a validation study, looking at the CloudClip, investigators looked at the recorded amount of near work done during the school period versus the actual amount of near work done as measured by the CloudClip. And you can see that questionnaires grossly overestimate the amount of near work done compared to the amount of time the children actually spend looking at their learning materials. And for those of us who teach students, or those of us who remember our days in the classroom, this should come as no great surprise. So what recommendations should we give to our children? We're going to talk about this more at the end of the webinar, but perhaps, again, importantly, we should take a holistic approach, just as the American Academy of Pediatrics. We know that there should be less time on the screen. We know screens are bad for your eye health, they're bad for your physical health, and they're certainly bad for your psychological health. Perhaps the advice, which I've given for a long time, is still valid. Don't hold reading material too close, have adequate lighting, 10 minutes of rest per 30 minutes of reading. That was proposed in 1892, or by Dr. Newman, advocate for the attention to the health of the pregnant mother and infant, regulation of the child's growth habits, more country life, more physical exercise, and reduction of home lessons. I look forward to the discussion at the end of the webinar, and I thank you for your attention.
Hi, my name is Jeff Walleen. I'm the Associate Dean for Research at The Ohio State University College of Optometry, and also the study chair of the Bifocal Lenses in Nearsighted Kids, or BLINK study, a randomized clinical trial sponsored by the National Eye Institute to investigate the effects of soft multifocal contact lens wear on myopia progression in children. And I should disclose that for that particular study, we received contact lens solutions from Bausch & Lomb, but that's the only disclosure I have related to myopia control. Today, we're going to talk about soft multifocal contact lens myopia control, orthokeratology contact lens myopia control, and then we'll compare the two of them to see which one might provide better myopia control. And finally, we'll talk about the safety of contact lens wear for children. So first, we're going to talk about center distance design soft multifocal contact lens myopia control. This is my investigation of a lot of studies of myopia control where they compare eye growth and myopia progression in children who wear single vision glasses or contact lenses to those who wear soft multifocal contact lenses. Each one of these is an individual study, and I compare how how much difference there is between those two groups in terms of myopia progression, which you can see indicated by these black bars. And if you follow the top of the bar over to the right-hand axis, you'll see how much that particular study found that they slowed myopia progression. And if you look at the red dots, you can see how much it slowed eye growth. And you follow that over to the left bar, and you can see over here how much they slowed eye growth. On average, soft multifocal contact lenses over a 2.1 year period slowed myopia progression by 0.3 of a diopter and eye growth by 0.15 millimeters. So this is a study related to daily disposable soft multifocal contact lens wear in which both myopia progression and eye growth were slowed by about 50 to 60% over a 3-year period. And that's similar to the findings that we had for the BLINK study, in which we investigated the role of the reading ad power in myopia control. So what we found was that the kids who were randomly assigned to wear the 250 ad power, or the highest reading ad power, actually had slower myopia progression than both the 150 ad kids and single vision kids, and that there wasn't a significant difference between single vision wearers and 150 ad wearers. And we found the exact same thing for eye growth. So soft multifocal contact lenses work as long as you use the high ad power. But then you might wonder, what's vision like with soft multifocal contact lenses? So before any kids could be enrolled in our study, we actually did a manifest refraction, put their results in a single vision trial lens, and examined their visual acuity. And we compared that to right after we put soft multifocal contact lenses with the 250 add-on. And you can see that the two groups had exactly the same visual acuity. So there really is no difference in vision between single vision spectacles and soft multifocal contact lenses. But what about the effect of orthokeratology on eye growth? And when it comes to orthokeratology, we can only measure eye growth and we can't measure myopia progression because they temporarily reduce the amount of refractive error that a patient experiences. So that's why you don't see any black bars in this graph. All you see are the red dots indicating how much eye growth was slowed over an average of 2.1 years in these various studies. And you can see that basically all of the studies, with the exception of one 6-month study and one 2-year study, slowed eye growth by at least 0.2 of a millimeter. These are the results of one particular study, the first randomized clinical trial to be reported with orthokeratology contact lenses. And it compares single vision spectacle wearers to orthokeratology contact lens wearers. While the difference may not look big here, that's because of the scale of the axis. Really, this is about a 40% slowing of eye growth with orthokeratology contact lenses. And all the studies we've talked about before have been in just your average myopes, so up to about 4 or 5 diopters of myopia. This is the only study that's been conducted in higher myopes. And in this particular study, the kids had on average 6.5 diopters of myopia, and they used orthokeratology to treat 4 diopters of that myopic refractive error. So the kids wore contact lenses at night, and then they had to wear glasses during the day to treat that residual about 2.5 diopters of myopia, of myopic refractive error during the day. So on average, this study found that these kids actually had slower eye growth if they used orthokeratology contact lenses by about 60%. So this is the first study to indicate that myopia control works in high myopes, at least as well as it does in regular myopes, at least for orthokeratology. But what about comparing orthokeratology to soft multifocal contact lenses? And I'm only doing eye growth here because that's really basically all the orthokeratology studies examine is eye growth. So you can see that on average, the orthokeratology contact lenses slow myopia progression by 0.27 millimeters over that average study length of 2.1 years. And soft multifocal contact lenses slow myopic eye growth by about 0.15 millimeters over, again, an average study length of 2.1 years. That sounds like it's a big difference because it's almost half of what it is. Basically, the soft multifocal contact lenses experience about half the myopia control as orthokeratology. But when you actually examine this, the difference between those two dots is 0.12 millimeters. And that equates to about 0.3 of a diopter millimeter over a 2-year period. So basically a quarter of a diopter difference over a 2-year period really isn't clinically meaningful. So I don't think that there's a clinically meaningful difference between those two modalities in terms of slowing eye growth. And there was a study that actually examined this. The kids in this study were allowed to choose what treatment they received, but before they received treatment, they all progressed at the same rate. And then after receiving treatment, both the orthokeratology and soft multifocal contact lens wearers progressed more slowly than the single vision contact lens wearers. And same thing happened for eye growth. Both the soft multifocal and orthokeratology contact lens wearers' eyes grew slower than the single vision, and there wasn't a significant difference between the two of them. So what I think you can take away from all that is that they both provide similar myopia control. But what about the safety of contact lenses in children? These are retrospective studies conducted by the Contact Lenses and Youth Study Group, in which they looked at the rate of discontinuation of contact lenses due to some adverse event, or the rate of corneal infiltrative events in soft contact lens wearers. What you can see is that the highest incident or the highest prevalence of each of those actually occurs in college age children, and the prevalence of each of those is actually lower in the youngest children. So that tells us that if we're willing to fit college age kids in contact lenses, we certainly ought to be willing to fit younger kids in contact lenses, especially if they get a myopia control benefit from them. And then Mark Bullimore did a review of the literature, and he compared the rates of corneal infiltrative events in children, or the rates of myopia or microbial keratitis in children, to adult rates. And you can see that they're very similar, possibly even slightly less in children. These are the corneal infiltrative event rates in a prospective study and 2 retrospective studies. Compare that to the adult CIE, symptomatic CIE rates. And this is microbial keratitis rates, probably the most important side effect that we can examine. And you can see that in youngest children, there were no reports. And in the teenagers, there were 15 cases per 10,000 years of wear, which puts it probably on the lower end of the adult range. And when it comes to orthokeratology, the kids experience microbial keratitis related orthokeratology, 14 cases per 10,000 years of wear, which puts it on the order of occasional overnight silicone hydrogel wear, or occasional or consistent overnight non-silicone hydrogel contact lens wear. So the kids do experience higher rates because they are wearing the contact lenses at night, but orthokeratology doesn't increase that rate any further. So it's important to tell these kids that if they experience a red eye or a painful eye or an eye that can't see, that they need to have their eyes examined by their doctor right away. So what I hope you take away from this is that both soft multifocal contact lenses and orthokeratology contact lenses provide similar amounts of myopia control, and they both provide both safe and effective myopia control in children. I had to go through this very quickly. I apologize for my fast speaking, but if you have any questions, feel free to email me at any time. Thank you very much.
Hi, everyone. I'm Kathy Lee. It's my pleasure to speak to you today about low-dose atropine and myopia control. Normal progression of myopia during childhood is becoming a hard question to answer. Here's some data that I use to inform what I tell parents. On the left-hand side from the International Myopia Institute, you can see myopic progression taken from children who were placed on placebo during myopia trials. You can see that Asians are much more myopic than Europeans or mixed races, but there's a gradual slowing of myopic progression as children age from 7 to 12 years of age. The COMET study showed that 48% of children have stable myopia by 15 years of age, 77% by 18 years of age, and 90% by 21 years of age. We're here to prevent high myopia. High myopia and its pathological correlates are much more associated with changes in axial length than changes in refractive error. And here's the thing I can never remember. A quarter diopter of increased myopic shift correlates roughly to 0.1 millimeters of increased axial length. I don't know where you've been if you haven't seen this graph. This is from the ATOM-1 and ATOM-2 trials of various doses of atropine. In ATOM-1, the drop was applied to just one eye only, and placebo was compared to 1% atropine. After 24 months, the drops were removed, and you can see there is a rebound catch-up myopia that is significant in the 1% atropine group. ATOM-2 did not have a true placebo group. It compared 3 concentrations of low dose atropine from 0.1% to 0.5%. While the children were on treatment for 2 years, you can see the effect was roughly the same, but the rebound off treatment was greatest for the higher concentrations, less for the 0.1% group. Those children progressing more than a half diopter during the 24-month washout were placed on atropine 0.1% again. And comparing the progression of the 0.1% over 5 years, now that's 2 years of treatment with a 1-year washout in the middle, comparing that to a historical placebo group from ATOM-1 allowed the authors to conclude that 0.1 atropine slowed myopic progression by 50%. There is a significant age effect in the children who progressed during the washout period. There was more progression for the higher concentrations of atropine, but there was also significantly more progression in the 6 to 8-year-old group than there was in the 8 to 10-year-old group or the 10 to 13-year-old group. Our next study is LAMP. We're kind of in the middle of it now. We have the first 2 years of data. This study has a true placebo group for just the first year. After the first year, that group was placed on the most effective treatment, which was 0.5%. You can see here on the top, it shows spherical equivalent change and axial length change, that there is a correlation between dose and efficacy, with 0.5% being the most effective dose on treatment. Now, this shouldn't be surprising given the ATOM-2 data. In addition, a recent publication showed that there's a significant effect of age on efficacy of treatment for all groups of treatment in the LAMP study. Now, things that were not found to correlate with treatment were parental myopia, compliance with drops, refractive error when placed on treatment, reading time, outdoor time. Age was the most significant thing that correlated with the effect on treatment. I like this data, but even though it's kind of busy, because it shows the progression of refractive change at different age groups on the 3 levels of treatment. These data allowed the authors to make the somewhat fun conclusion that if you're a 6-year-old on 0.5% atropine, you're going to have a certain level of progression that is equivalent to a 8-year-old on 0.25% atropine and a 10-year-old on 0.01 atropine, demonstrating the slowing of myopic progression with age. Now, remember that the morbidity of myopia is most highly correlative to axial length. And, the comparison here isn't quite as dramatic. So the axial change of a 6-year-old on 0.5% atropine is equivalent to that to a 7-year-old on 0.25% atropine and an 8-year-old on 0.01% atropine. The next phases for LAMP involve each group being randomized to treatment continued or washout for 12 months. I think that's going to be particularly interesting. And in phase 4, the washout progressors, those progressing more than a half diopter during the washout time, will be replaced on treatment for 24 months. Those studies took place in Singapore and Taiwan. We're starting to do, we have randomized trials undergoing in the United States, but here is a look at a retrospective case-controlled study that showed that atropine has a decent effect over 2 years of use for children in the United States. Currently, there are several studies in progress in the United States for low-dose atropine. The myopia treatment study 1 through the Pediatric Eye Disease Investigator Group, and I have the privilege of being an investigator for this group, compares 0.1% to placebo, 24 months on with a 6 months washout. We're just starting to have some of the children complete the trial, and I'm really looking forward to these data. The primary outcome is a comparison of spherical equivalent at 24 months, and we should have these data in June of next year. SIDNexus is sponsoring the STAR study. This compares 0.1% to 0.3% to placebo. This study uses deuterated water, which is thought to stabilize low-dose atropine, which is notoriously unstable in non-acidic pH. This is a 36-month on study, 12-month washout if they had the medication, and the placebo group will be re-randomized. The primary outcome is a cut point outpoint of myopic progression greater than 3/4 of a diopter at 36 months. Nevicar, now Viluma, is sponsoring the CHAMP trial. This compares 0.01 to 0.02 to placebo. Again, the 36 months on treatment, at which point the participants will be re-randomized to 0.2% or placebo for 12 months. They're encompassing children between 3 and 17 years in the study, but the primary outcome really studies the group between 6 and 10 years and has a cut point of a half diopter of myopic progression. Inovia is sponsoring the Chaperone trial. This uses a microdose of 0.1 or 0.01 versus placebo for 36 months. The children are then re-randomized and the study continues for another 12 months. Again, this one evaluates a cut point spherical equivalent. All of these studies are studying axial length as a secondary outcome. You know, there are several unanswered questions in myopia. I think we could do a talk on each one of these. You know, we're trying to figure out how should low-dose atropine treatment be individualized. We know that the younger children are more significant progressors, and many of us have switched to using a higher dose of atropine in that group. Where does atropine exert its effect on the eye? Unlike other modalities to treat myopic progression, the refractive change does not correlate particularly strongly with the axial length change, suggesting that atropine exerts its effect somewhere else on the eye besides affecting axial length. Are the axial length change that are caused by atropine going to be sustained long-term? How do I know that my patient's low-dose atropine is stable? Low-dose atropine is notoriously unstable, and it's been suggested that one way to do this is to place your patient on atropine in just one eye for the first month, have them return and see if there is a difference between pupil size and accommodative amplitudes between the two eyes. And finally, how do we stop atropine? Are we going to taper? Are we going to stop? The end game in atropine use is very unclear at this point. Thanks so much for letting me talk about a fascinating topic. I could go on all night. It's really been a pleasure.
Hi, my name is Amy Jeffrey, and I'm going to discuss my myopia management in private practice. I have no financial obligations to disclose. Before 2013, the evaluation of the myopic patient in my clinic was boring and quick. I had little to offer regarding prevention or progression. Now I'm very interested and invested in these patients, offering helpful advice and options to retard progression. My personal journey started in 2013 after being part of a meeting in Singapore when Dr. Tan presented his 2-year data using dilute atropine to retard the progression of myopia. When I returned to the States, I began to offer these drops to my patients with very encouraging results. Over time, my approach has evolved. Presently, when I diagnose a patient with myopia, I begin with asking the family history regarding myopia. I educate them on the ocular comorbidities and we discuss lifestyle recommendations, pharmacological interventions, and refractive correction. There is no cookie-cutter approach to these patients. There are multiple factors to consider, and each patient needs to be evaluated individually. My approach is very dependent on their age of presentation of their myopia. To begin, we will discuss children that are less than 5 years of age. The initial visit of a young patient with myopia is frequently a result of a failed vision screen. This is a great opportunity for me to educate the parents regarding lifestyle. I discuss the recommendations of 2 hours of outdoor natural light a day. I discourage the use of handheld electronics, specifically phones and tablets. I recommend no children under 5 should have access to phones or tablets, but I recognize there will be exceptions, but strongly encourage these times to be exceptions. I usually am not prescribing myopic spectacles at this age group unless it will improve their daily activities or there's a risk of amblyopia without the glasses. The decision with this age group of child to intervene further is determined by the family history of myopia, the level of myopia, and the parent's level of interest. I rarely start them on atropine drops at this initial visit. I will follow them at 6 months, and as the child becomes older, become more aggressive with treatment options. Now, with the initial visit of the older myopic child, I discuss their family myopia history. I spend time discussing the child's lifestyle to understand the risk factors for progression of the myopia. For example, if they are big readers, what sort of athletic activities they're involved in, or generally how they spend their free time. I spend a lot of time reviewing the best lifestyle decisions that will influence their myopia progression. I recommend outdoor natural light 2 hours daily, frequent breaks with their near work, the 20-20-20 rule. Encourage them to make good choices regarding their electronics for pleasure. The larger the screen and the further away will be less harmful for their eyes. With these children, I do place them in spectacles because I want their best vision attending school. I encourage them part-time wear and removing them for prolonged near work, depending on their myopic power, of course. The big book readers that need to wear their glasses full-time, I consider adding a bifocal. I advise all the kids to not read in the car. In this age group, at this first visit, I'm often recommending dilute atropine. I do not wait for the progression as I did in the past. Parent level of interest is obviously crucial. I will usually start them on atropine 0.01% at bedtime, telling them they will probably be on these drops for at least 4 years. There are some exceptions when I will start with a higher percentage, an older child that's already very myopic or extremely darkly pigmented iris, or if they've had an older sibling that broke through the 0.01%. Then I will see them back in 6 months. At the 6-month follow-up, I do a refraction, dry or cycloplegic, depending on their age. I will do a cycloplegic refraction at least yearly on everyone. The refractive error change and the actual axial length measurement are highly correlated. Most studies will follow patients with axial length measurements with an IOL master, but I do not in the clinic follow them that way. I find it costly to the patient and not practical in my clinic. And most importantly, I do not feel these measurements will change my management. At this visit, I reinforce lifestyle recommendations. Many times the children need to hear these again. I review the specifics of the drop use to make sure there are no obstacles to daily and consistent use. I want to ensure excellent compliance. For example, I make sure parents are putting in the drops and not relying on their child. At this 6-month checkup, if there's been very little change, I will maintain them on the 0.01%. But if they've had a bit of a shift, which is 0.5 or more, I will entertain switching them to a stronger percentage. But I warn them of a possible transient blur at near in the mornings the first few days after they switch. Another option I will give is the MySight contact lens. This is not my initial treatment, but rather an additive to the atropine. Though it is a wonderful option, there are a lot of limitations. The contacts are not available over a -6. You cannot have significant astigmatism. The ability or interest of the child, the cost, and they need to wear them for at least 6 out of 7 days. If they are breaking through the 0.05%, I will strongly encourage them. If they're doing well on the 0.05 or the 0.01, I just offer them this option. Ortho-K is the last option which I rarely recommend. The decision when to stop the atropine is complicated, since there's not a great study this time to help us navigate. I counseled the children when I began treatment that they will usually be going on these drops for at least 4 years. The decision to stop the treatment is age dependent. I tend to not stop the drops in the girls less than 12 or the boys less than 14. If they've been stable and they're older, I will discontinue the atropine. I follow them back in 6 months to make sure there's not been any significant progression. In summary, the factors I take into account when to begin treatment with atropine is the age of the onset of the myopia, the family history of myopia, the parent's interest in halting the progression, the ease of the administrative drops, and the ability to manage contacts. But I do not wait to witness significant progression of the myopia. I try to identify when those children are most likely to progress, but I do feel it is better to overtreat a few than to undertreat, since every diopter of myopia matters by increasing the risk of sight-threatening comorbidities. I consider atropine a low-risk option and peripheral defocusing contacts wonderful, and hopefully defocusing spectacles in the near future. In summary, now we have significant therapeutic options and are recognizing the importance of early diagnosis and management of myopia. I now discuss the ocular health concerns of myopia with the parents and children, which I did not do when I did not have treatment options. By discussing these comorbidities, the families are enthusiastic with my lifestyle recommendations and treatment options. With these pharmacological therapies, contact lenses, and glasses options, we can give children and family hope and guidance rather than just prescribing glasses. It is a great time to manage these patients, and there's plenty of them to help. Thank you.
Hi, I'm Dr. Bob Akhmachdadi from the Southern California Permanente Medical Group and the Kaiser Permanente School of Medicine. I want to thank the organizers of this meeting for giving me an opportunity to talk about myopia screening and parent education in a large healthcare system. I receive research support from Genentech, but that's outside the scope of what we will talk about here today. There are several unique aspects to working in a large healthcare system, especially when we think about how to tackle a large public health problem like myopia. Within Kaiser Permanente, we have the ability to coordinate care across ophthalmic and non-ophthalmic specialties. Our pediatric ophthalmologists can work closely with pediatricians and family medicine doctors, as well as optometrists, to help develop clinical paradigms that best deliver care and streamline the patient experience. We have access to large and searchable databases of patients, which allow for both clinical and research programs to improve outcomes. And we have the ability to employ larger public healthcare initiatives because of the large population of patients that we serve. Kaiser Permanente is obviously a very large organization. Just within Southern California, we have 4.6 million patients. That's more people than 25 states in the US. We have 6,000 physicians and over 100 medical offices, and our patients are broadly representative of Southern California, both racially and socioeconomically. We've had electronic medical records since 2005, which means we have a wealth of data that we can use for clinical outcomes work. And we have 450,000 children between the ages of 5 and 12 years old. Patients of Kaiser Permanente benefit from belonging to a single, centralized, integrated healthcare system. Pediatricians and pediatric ophthalmologists work closely together to develop the screening and referral paradigms for vision problems. Currently, JVAS is used as the screening method. It's free to download and runs on Windows computers which are ubiquitous in any clinic setting. The screening is done in the pediatric clinics at the time of the annual wellness exam. I have to quickly acknowledge Dr. Sheval Shah and Dr. Ashish Mehta, who've worked tirelessly on these screening programs and have also worked with our pediatricians very closely, and have also done a lot of research and analysis on how these programs are performing and how to improve them in the future. Several years ago, we decided to look at myopia from a bird's eye view in our organization to try to find contemporary and relevant estimates of the prevalence of this condition. What we found was that about 41.9% of patients who were younger than the age of 19 were myopic in Southern California. Here we can see a more detailed breakdown, and we see that the age 17 to 19, almost 60% of children are myopic, and almost 5% are highly myopic with a refraction of greater than 6 diopters of myopia. We know that myopia globally is a significant public health problem, and we saw from the prior data from our previous publication that it impacts a high percentage of the children within our organization. So the question that we asked was, how can we develop programs for education and intervention that best leverage the strengths of our large organization? One thing I briefly want to mention is the American Academy of Ophthalmology's white paper on myopia that was published this past year. The AAO convened a task force back in 2019, and the subsequent publication in ophthalmology discusses the importance of myopia as a public health challenge and also reviews important strategies around myopia control on a both population and individual basis. This is a good paper as a point of reference for future discussions around myopia control strategies. Specific to today's talk, some of the proposals in this paper have actually been employed by KPSC for several years, and I think our experiences rolling out these programs can help others employ similar strategies. We've taken on the task of trying to develop myopia control strategies by having a multi-pronged approach. For one, we've worked closely with our pediatricians. As ophthalmologists, we've attended and spoken at their CME events and tried to educate them on the importance of myopia as a public health problem. We've also worked with our pediatricians to help them encourage outdoor time when the patients come and see them for routine visits. And we've also worked with our electronic medical records group to incorporate questions around outdoor time into the patient intake experience inside of our electronic medical record. We've also developed myopia control classes, where myopic patients are identified by searching the KPSC database. Patients and their parents are subsequently contacted and invited to attend a group class where the pathogenesis and risks of myopia are discussed. Additionally, we have discussions around myopia control strategies, which are ultimately offered to the patients. We've additionally worked with the local surrounding communities and done public health outreach by meeting with PTAs and schools to educate patients, parents, and educators about the importance of outdoor time in the prevention of myopia. Here you can see an example of a flyer that would be given to one of our pediatrics patients when they see their pediatrician. These kinds of flyers and educational materials are broadly available and distributed to children when they come and see their pediatricians, and they emphasize the importance of outdoor time in the prevention of myopia. Here you can see a screenshot of what our electronic medical record looks like. When patients come for pediatric visits, they actually get asked this question now routinely. Does your child spend at least 2 hours outdoors daily? This functions as a great springboard for doctors to have conversations with their pediatric patients about the importance of outdoor time, and it also gives us a discrete variable in the electronic medical record that we can track for clinical outcomes and research purposes in the future. For the past several years, we've been holding classes on myopia control for our patients. Previously, these were done in person, but we transitioned to a virtual format due to COVID-19. This virtual format, where the seminars are recorded and available for viewing at a later time, has actually proven to be very popular because of the increase in convenience and accessibility for patients and their families. So here's how the myopia control classes work. We query the electronic medical records regional myopia PEDS list to identify those patients that might benefit from these classes. Essentially, we're looking for those children with more than 1 diopter of myopia. After we identify those patients, they and their parents receive an email or letter notifying them about these educational seminars that will help them learn more about their condition and introduce them to different treatment options. Those patients and parents who sign up then attend a class where they learn about myopia, its pathogenesis, the risk of long-term issues associated with myopia, as well as the different options for reducing the progression of this condition. Patients' charts are pre-screened to identify which patients might be eligible for atropine or ortho-K. Those patients that are possible candidates for these interventions are then offered ortho-K or atropine. Those who elect to move forward with these interventions are then plugged in to the appropriate treatment and monitoring program. Those who elect for ortho-K are sent to optometry, where they receive further evaluation and management. Those who are interested in atropine receive their prescriptions and are subsequently monitored by our eye monitoring center, which provides teleophthalmology services for Kaiser Permanente, Southern California. The patients in the myopia program who are on atropine are regularly contacted by the eye monitoring center to assess how they're doing, if they're getting their prescriptions, or if there are any issues that are arising. Central to all of our efforts is the concept of continual assessment of quality and improvement. We continually circle back to those patients who attended the virtual seminar. For those that did not elect for intervention, we asked them why they didn't elect for intervention. For everyone that attended the seminar, we asked them what they thought about it. And for those in the interventional arms, we were constantly checking in with them to seeing how they're doing. We've worked to leverage the eye monitoring center's experience delivering teleophthalmology care to improve the myopia control program experience for our patients. By frequently touching base with them to identify the barriers to care, we've found that there are issues around access, copay, and short shelf life when using atropine, as well as concerns around costs and frequency of visits when dealing with ortho-K. By identifying these issues, we've worked to try to streamline the services we provide our patients and reduce the barriers to them receiving myopia control strategies. Our hope is that in the future, we can be more targeted in our myopia control strategies. One key step in that is improving our risk stratification. Currently, when we develop and discuss myopia control strategies, we do so sometimes in an overly broad way. We've been trying to identify risk factors for myopic progressions so that we can potentially be more targeted in our approach. One of our recent publications has looked at race and found that Asian American students are more likely to have myopia progression compared to their Caucasian counterparts. It's our hope that in the future, using this kind of data will better identify those patients that would most benefit from intervention. I want to thank Andrea Wong, our department administrator in the Eye Monitoring Center, as well as Dr. Donald Fong, the previous physician director of the Eye Monitoring Center, who was instrumental in getting many of these programs off the ground. I also want to thank Ashish Mehta and Sheval Shah, who I both mentioned previously, have worked tirelessly to help the pediatric ophthalmology vision screening experience. Thank you, everyone, for attending today's talk, and I look forward to hearing more from you during the question and answer session.